Well, welcome everybody to Multipurpose Prevention Technologies, MPTs, Impact Investing for Global Reproductive Health. So what are MPTs? MPTs are, in short, they're just an instrumental tool for a healthier planet. Multipurpose prevention technologies are broad spectrum sexual and reproductive health prevention products that are in development that can combine contraception with STI prevention and HIV prevention at the same time. And many of these products that are currently in development are also designed to be initiated and used by women. So I'm your moderator, Laura Vida, and I want to thank SoCap for having this conversation here at the conference. And I'm happy to introduce you to our panelists who have come from far and wide to be here with us today. Our first speaker is Dr. Manjula Lusti-Narasimhan, and thank you for flying late last night from Geneva, and who will unfortunately have to leave at noon, so to hop back on a plane. That's heroic traveling to be here today. And Manjula is a senior scientist at the Department of Reproductive Health and Research of the World Health Organization. And she's going to talk about the global need for MPTs, both in the developed and developing worlds and the social impact of MPTs. Then we will hear from Dr. Bethany Young-Holt, who's the Executive Director of CAMI Health, who will talk about the innovative, multidisciplinary organization that is leading and coordinating the development of this field. The Initiative for Multipurpose Prevention Technologies, the IMPT, which is enabling scientists, advocates, and funders to come together and transcend barriers to innovation to grow the field. And she'll also be talking about how this field generates social and financial return on investment. Then we will hear Trisha Wood Santos, who joins us as a program officer on the family planning team from the Bill and Melinda Gates Foundation. And Trisha will be sharing evidence for the salience and impact of MPTs with market research that is done by Ipsos and funded by the Bill and Melinda Gates Foundation, and talking about why MPTs are a smart investment. And Dr. Joseph Romano, who's the president of the NWJ Group, an independent consultant to CAMI, and the chair of the IMPT Scientific Agenda Working Group. And he's going to give an overview of the biotechnical innovations that are already underway in the field and how funders and scientists are working together to actualize MPTs and bring them into women's hands. And so I'd like to bring Manjula to the podium.
So, good morning, everybody. This is a real privilege for me to be here today, and my role today is really to set the stage and to explain why MPTs are needed. And firstly, I just wanted to put on stage what the different sexual and reproductive ill healths could be. Generally, they result from unsafe sex, and because of a woman's inability to either negotiate safer sex or access to certain commodities or products, there are a number of reproductive health and sexual health consequences to that. Essentially, unintended pregnancy and sexually transmitted infections, which include HIV. And when we talk about sexual and reproductive health, at least from the World Health Organization's perspective, we are talking about a comprehensive policy bringing together a promoting of sexual health, providing antenatal care, delivery, and postpartum care to women, combating all STIs that include HIV, providing family planning, providing infertility services, providing services against unsafe abortions. So we're really talking about a comprehensive look at sexual and reproductive health for women and young girls. And this is a document, the Global Reproductive Health Strategy of WHO is endorsed by the 191 member states of the UN, but in reality we do know that things are very siloed, both at a funding level and at a service delivery level. And the consequences of that is that there are a number of very critical public health issues. Cervical cancer deaths among women, which are preventable if they are screened and treated properly. is still resulting in over 250,000 deaths per year, and it's also one of the leading causes of cancers in women living with HIV. Maternal mortality is something that's still unacceptably high, with women dying every day. And of course, HIV is, as we just heard, there's one woman is newly infected with HIV every minute. And so this continues to be a problem that's extremely high. And what's important to see here is that mainly in sub-Saharan Africa and Southeast Asia, this is an area where all of these issues are compounded, are very seriously present in one region. And for people living with HIV, we know that it's a little bit plateaued off, but there's still millions of people affected with this. And as we just saw, women and young girls are particularly affected. And heterosexual transmission of HIV is now a very important aspect to take into account. So women, basically to say that women need more treatment options, and they need these options to prevent HIV, STIs, preventing unintended pregnancies for themselves, but also for their families and their communities. If we look at STIs, as you just heard, also, this is something that's a global problem. And the numbers that you see here are for curable STIs. So yes, they can be cured, but having them or having repeated STIs can lead to other consequences, such as infertility, such as pelvic inflammatory disease, and these have a lot of negative consequences and in terms of the ability of women to function on a daily basis. So we look at contraception. Close to half of all the pregnancies around the world are unintended, and leading to 80 million of unintended pregnancies per year. And so many of these women have an unmet need for contraception. There is a wide array of contraception that's available, but they just don't have access to this contraception. And of course, as we just saw, a lot of these women die or have other sexual and reproductive health morbidities that include, for instance, consequences of unsafe abortion. 13% of actually all maternal deaths are due to unsafe abortion, and many others suffer very serious morbidities. So these are some of the methods that are available. I mean, we know that these range of methods are available, but the issue is that women either do not have access to them, or do not use them correctly, or not able to afford them. There's a number of issues, particularly in resource-poor settings, where we need to do more. And when it comes to having a method that can protect both STIs, including HIV, and for unintended pregnancy, we only have the condom. We have the male and female condom that is one product that could protect against all of this. But we know that even in couples, only 8% of couples use condoms. We know that in many situations, female condoms are not available or too expensive. We need to do more. And the underlying message here is that women need more options to meet their needs and their goals through their lifetime. And this is not something I've mentioned, the sub-Saharan African region, I've mentioned Southeast Asia, but this is not something that's just for across the world. This is very much a problem here in the United States and in many other settings. So here, nearly half of all pregnancies in American women are also unintended. STIs are very common here, and there are cases of HIV occurring that could be prevented. And so having MPTs, having products that meet the needs of women and young girls, not only in the States, not only in sub-Saharan Africa, but worldwide, and that would really make an impact on their health, the health of their families, the health of their communities, and would be really essential once they come to market, once these products are developed and made available to women, will be key in making sure that all people have access to health. Thank you for your attention, and I will go on to Bethany. Thank you.
Thank you, everyone. Thank you so much for being here. I am Bethany Young-Holt, and I am going to talk to you today about an innovative international collaborative that is using a collective impact approach to advance the development and access of comprehensive sexual and reproductive health products. This initiative is referred to as the Initiative for Multi-Purpose Prevention Technologies. And as Manjula has described, there is an intrinsic link between unintended pregnancy, HIV, and other STIs, and millions of women around the world have a need for protection against these combined risks. But the only available protection product available to these women right now are male and female condoms, which are great if they are used correctly and consistently. But as we all know, this is just not feasible for millions of women and for millions of couples. So MPTs, or multi-purpose prevention technologies, are a new class of products that address the simultaneous risk of unintended pregnancy, HIV, and STIs. And what's really exciting about the evolution of this new class is the active effort to engage the input of women, the end users, throughout the product development process. So the MPT field is building itself upon about over 50 years of research and contraceptive work, 2 decades in the area of HIV prevention, namely microbicides. Some of the MPTs in development are going to look very familiar to you, or at least your partners. We're talking about intravaginal rings like the Nuva ring that would be combined with a contraceptive hormone and an anti-HIV drug. There are diaphragms that would be combined with an anti-HIV drug. There are also tablets and gels that are in development that could allow a woman to get pregnant, because that's a reality for many women, but also protect her from an infection, say HSV or HIV. So research is also underway on novel approaches as well. The MPT is working to advance really a suite of MPT products that can address the diverse needs of women throughout their lifetimes and according to their geographical region. So, for example, a woman in college at UC Berkeley is probably going to have very different needs and desires for protection than a married woman with 6 children living in a village in Kenya. So the MPT field is complex, and the initiative is not only bringing together researchers that are working in the areas of contraception, HIV, and other STIs, but it's also bringing together a multidisciplinary cadre of researchers, those with social behavioral expertise, manufacturing, formulation, to really inform these various issues that really make this field complex, related to industry, manufacturing, acceptability, and dosage forms. So research in the area of sexual and reproductive health has traditionally been siloed. You've had researchers tending to work in their areas of contraception, others in HIV, others in other areas of STI work, without a lot of opportunities or incentives to really come together and share their areas of expertise and look at ways for collaboration. Through the initiative, we are bringing these different partners together in recognizing the comprehensive health needs of women. We are using this collective impact approach to bring all of these different levels of expertise together. So to ensure the progress towards the initiative's shared goals and agendas. The initiative has identified 4 priority areas relevant to successful development. These areas really focus on advancing the scientific agenda, optimizing and enhancing funder investments and collaboration, advancing strategies for advocacy and market development, and also strategies for ensuring that the input from women are engaged throughout the process. So as I've mentioned, top researchers from various fields are coming together to develop criteria and strategies to really advance the product development. And my colleague Joe Romano is going to be going into a lot more of this shortly. The other challenge that this field has is that not only is the science complicated, but developing new prevention products such as MPTs is going to be really expensive. The vast majority of MPTs in development right now are in development by funding agencies, U.S. And international government agencies and foundations, which have obviously financial limitations and resources during this age of time. The traditional way that funding has been done through governments and these funding agencies has been through funding individual ideas and issues, which has really not encouraged collaboration and opportunities for sharing ideas. So through this initiative, we have convened a supporting agency working group or committee that brings together funding agencies and experts from the philanthropy end and governments to really work together. We also have regional working groups that are quite active in India, South Africa, Kenya, China, and the United States that are helping to inform not only what women need in terms of product development, but the engagement of these working groups that are experts, researchers in these countries are working with their ministries of health so that when MPTs are ultimately available, they will be accessible to the people that most need them. If you all would like to learn more about how we're using this collective impact approach, we are working with WHO right now and we'll be launching a supplement on MPTs in the International Journal of Obstetrics and Gynecology that'll be coming out in the fall. So you might be asking, why invest in MPTs? Well, this initiative is really forging a new real paradigm for how product development in the area of sexual and reproductive health is done. We are engaging in really listening to the needs of the women in the community and in integrating that into the whole product development process. So you'd be investing in a field, in a process that is efficient and is really scaffolding the product development process. So thank you very much.
Hello, thank you. I'm Trisha Wood, and I'm a program officer at the Gates Foundation. And our mission at the Gates Foundation is that all lives have equal value. And today I'm going to talk about 2 of our program areas that are working together. So we have our HIV team that works on new innovations for HIV prevention, as well as helping people who are already infected with HIV lead long, healthy lives. Our family planning team, which I sit on, also invests in new contraceptive technologies excuse me, to meet the needs of women, as well as country solutions, with a goal of reaching an additional 120 million women with access to family planning by 2020 and setting the stage for universal access beyond that. Together, these 2 teams are working to see how we can create greater efficiencies and effectiveness in meeting unmet sexual and reproductive health needs of women through the creation of MPTs that protect against HIV and pregnancy. To date, we've actually have not funded a lot of products. We've funded some early discovery work on delivery platforms, such as vaginal films and vaginal fibers, but most of our research has been, most of our funding has been on market research and understanding the end user and potential product attributes that would be desirable before investing in a specific technology, which is what I'll go into now. We funded some work recently that Ipsos conducted looking at market research for potential MPT products. And there were two objectives. One was a qualitative study to understand women in South Africa, Uganda, and Nigeria with respect to their sexual behavior, contraceptive use and perceptions, as well as HIV perceptions of risk and use of preventive products. And then the second part was a quantitative study looking at acceptability of 4 potential forms of vaginal film, vaginal ring, injectable, and implant. The results from this at a high level, that 93% of women found an MPT that prevented against HIV in pregnancy to be acceptable and desirable, compared to 4% wanting an HIV-only product and 2% wanting a contraceptive-only product. And this was consistent across the 3 countries. In terms of how acceptable having an HIV test prior to using an MPT, particularly if it's an ARV-based MPT, 3/4 overall thought that was completely acceptable. Antiretroviral treatment. It's a treatment. Joe knows more. Joe's the HIV specialist.
ARV stands for antiretroviral. It's a category of drugs typically used for the treatment of HIV, but it's also being developed for the prevention of HIV.
Yeah, thank you. And then having an HIV test every 3 months, which would be required. It's to protect against resistance of those drugs, the reason for the frequent testing. So 2/3 thought that testing would be completely desirable. Again, Uganda had higher acceptance of both of those things than the other countries. When women were asked to pick the most acceptable product or what product they would pick if all 4 were available today, the rank order is implants, injectables, vaginal film, and a vaginal ring in that order. That's consistent with South Africa and Uganda. However, in Nigeria, after implants, it was vaginal films were slightly more acceptable than injectables. And I think this was also found to be consistent with youth preferring a film, which we call an on-demand product, meaning it could be used at the moment of intercourse and not needed, not a continuous use product. And then when women were asked what would they pick if only one MPT were available today, it is still the same rank order with implants and injectables being the top 2, but actually quite a few women prefer or liked the vaginal film at 50 or 60% per country. And looking at the ring, nearly half of the women in Uganda said they would use the ring if it were the only one available, and 36% overall said they would use the ring if it were the only one available, compared to only 9% using the ring if all 4 products were available. This is a separate study not funded by the foundation, but I thought I would just call some attention to some US data that was done looking at acceptability of different attributes for MPT microbicides among women in Northern California. And it was a conjoint analysis and shows that the spectrum of disease was the most desired attribute, meaning the number of conditions or diseases that the product would prevent against, followed by efficacy compared to condoms, duration of action, applicator type, method of distribution, and messiness, basically, volume of leakage. What was interesting from this study is that nearly 50% of women were worried about getting pregnant, compared to only about 30% worried about contracting an STI, and that most women would have preferred a contraceptive packaged with an HIV or STI prevention product. So in thinking about some of the market research that the foundation is funding, we're also thinking about the market potential and public health impact for investing in MPTs. And as Manjula pointed out, in the US, 50% of pregnancies are unplanned, almost 20 million STI infections a year. So there's a great need in the U.S. For Sub-Saharan Africa, which is the focus of the Gates Foundation HIV and family planning teams. We know there's over 30 million women in the 10 highest HIV incidence countries, of which 20 million have an unmet need for family planning. What's also interesting about these graphs is that in those countries where HIV incidence is higher, there also tends to be a higher use of contraceptives, which our theory is that if women are already in the habit of using a contraceptive, they're more likely to adopt and continue to use an MPT if it were to become available, which would lead to greater public health impact. In terms of return on investment, unfortunately we don't, as far as I know, have any data on the return on investment of an MPT specifically for HIV and FP, or family planning. What we have done is some modeling on male circumcision, showing that if you could achieve 80% coverage of male circumcision in 14 African countries, you could avert greater than 3 million HIV infections and save $16 billion. For family planning, it's much more well documented, the return on investment for maternal and child health. And if the global community reaches its goal of 120 million additional users of contraceptives, by 2020 we would have averted more than 200,000 maternal deaths and 3 million infant deaths. Also knowing that spacing pregnancies by 2 years or more decreases child deaths by 13%. And for every dollar invested in family planning, it leads to approximately $2 to $6 of social sector savings in sub-Saharan Africa and $13 in savings in Asia. So in conclusion, I think what we're learning is that there's no one MPT that's going to meet everyone's needs. You need a spectrum of products, just as you do with contraceptives, and that adding an HIV or STI prevention product to a contraceptive is most likely to be more likely to be accepted and taken up. Products that are known, so implants and injectables are not very common in the US, but they're quite common in sub-Saharan Africa, and so those types of products are more appealing because they're already known. On-demand products or intermittent use products could be a valuable method for young women or women who have infrequent sex. And new product forms, so vaginal rings are more known in the US but not known in sub-Saharan Africa, are going to take more time for building awareness and demand. And from what we know with family planning and HIV prevention, the social and financial return for MPTs could be quite great. So, thank you.
Hello, everyone. I'm Joe Romano. I'm grateful to be here. Thankful to the SoCap people for allowing me to be part of this panel. I'm also grateful to the previous presenters who gave a comprehensive background on a lot of the issues facing MPTs, so I don't have to cover that. The purpose of this presentation is to talk a little bit about the science, technology, and actual product development that is currently ongoing and is being contemplated for the future. So what is the realness of MPT product development at this point? So any product development is complicated. It's technically challenging, and it involves an array of regulatory challenges that all products have to go through. And when you're talking about products that are going to address 2 indications, it gets more complicated. It'll involve more than one drug. Here we're talking about 4 essential sets of factors that have to be thought about strategically before you start. What are the indications that you're going to put together in a product? Which drugs with which mechanisms of action? Which dosage forms make sense? And Trisha just spoke a little bit about some of the complexities there. What do the populations want? Because you can make something that works, but if it's not desirable, they won't use it and it has no impact. And the way this is administered and the frequency with which it's administered also matters. Injectables can be administered once every 3 months. Implants can be for years, but a vaginal film or gel could be very brief. So which ones make the most sense? And to sort this out, you kind of need, the field needs some prioritization. And the initiative for MPTs, which Bethany talked about, has been very active here for several years, trying to help prioritize the needs for this field in terms of product development. And it focused on a number of issues. So first was which drugs make sense for MPTs. For the prevention of HIV, the clear consensus is that those antiretrovirals, which I mentioned earlier, make the most sense. These are drugs that are already approved frequently for HIV treatment. They have established safety and efficacy profiles, and they're quite specific in terms of their target. They target HIV, and they're very efficacious. There's downsides. They have side effects like all drugs. They are associated with HIV. There's a stigma that comes with that, particularly in certain populations around the world. And they're not cheap. On the contraception side, there's a long history of hormonal contraceptive products, and there's lots of biology and safety data known about those drugs, and there's various dosage forms. So we have a lot to draw on from there. But again, these are safe drugs with a long history, but not without side effects. On the STI side, it's more complicated. We don't have really good candidates yet. There are some drugs being considered for the prevention of STIs, but STIs are very complex. There's an array of STIs. There's viral STIs. There's bacterial STIs. And finding drugs that can be specific for those could be challenging. This represents a gap in the MPT field now. Besides the drugs themselves, it's the dosage form, the delivery platform that has to be considered. What's going to be acceptable, as well as achieve the necessary level of delivery of drugs. Now, there are various strategies here. The simplest for an MPT is a co-administration. You can take an injectable, for example, that's used for contraception, and an injectable that could prevent HIV for, let's say, 3 months, and just co-administer them. You could also put both of those injections into one package and supply that as a product, and that can be administered at the same time to someone. That's a little more efficient than having 2 separate, completely independent products. But thirdly, you can have co-formulated, where both the HIV prevention or the STI prevention is in the same injection dose as, say, a contraceptive product. And that's where the efficiencies can really be achieved. The point that Bethany mentioned was that there's not going to be one product type that satisfies all needs. We're going to need a suite of products that can address the temporal needs of a user and the geographic issues that are relevant to product use. And without an array of products, it'll be a very limited segment of the population that gets covered. So MPT development involves multiple types of products. So these are various dosage forms with various indication combinations. And we've talked about this and you've heard about this here already, what these options are. Specifically, where the current product development for MPTs is focused is based on some work that the initiative, the IMPT, was involved with and other organizations over the past couple of years. Surveying product developers, local country experts, people with technical expertise in these kinds of product development efforts to see what made the most sense. And a list of priorities came out, which allows for some focused investment. These are sustained release devices like vaginal rings, like NuvaRing, long-acting injectables like Depo-Provera or NetN for contraception, and on-demand products which could be used at or around the time of sex. And again, with this set of products, you can cover lots of the population. So I'm going to spend a minute on how MPT product development currently happens. There are first development organizations, and these are groups that are actively developing MPT products. And there's different kinds of them. The primary set right now are the so-called product development partnerships, or PDPs. And there's a number of these, which you're probably familiar with, that are involved in all kinds of diseases, whether it's malaria or HIV vaccine. 2 that are relevant to the MPT field that are provided as examples here are IPM, which is the International Partnership for Microbicides, and CONRAD, which was previously, historically, a contraceptive organization, but has gotten into HIV prevention as well. These are nonprofit groups which get access to drugs and delivery technologies, receive funding from various sources of financial backing, and they work on the actual development of these products. There are also biotechs involved in MPT development, small organizations that, again, have some intellectual property around the drug or delivery technology that they're trying to use for purposes of developing MPT products. And there's actually large pharma involvement as well. Merck, for example, which bought Schering-Plough, which bought Organon, now has NuvaRing. And they are working in partnership with NIH to see if, in fact, their NuvaRing technology could be harnessed to deliver drugs that prevent HIV as well. I'll shift to the other side of the slide. Aside from the groups that are actively engaged in the development, are groups that partner with those groups engaged in the development. And this could be a pharma organization that donates drugs, makes drugs available by license to the developers that are engaged in the actual product development. Small biotechs that provide component technologies to the product developer of an MPT. There are a number of academic groups currently engaged that are funded by the government to develop these kinds of things. There are contract manufacturing organizations that are associated with the production and scale-up, other NGOs, procurement organizations, and down it goes all the way through the access end of MPTs. At the center of this, though, are the funding organizations. And right now, that's primarily governments, including agencies such as the National Institute of Health and USAID. There are some EU groups involved, not too many at this point. And there are also foundations. The least represented area on the funding side is private money. So this represents an opportunity for those organizations to consider investing in MPTs, because much of the investment is already covered in a non-diluting fashion by other organizations. So the market research that Trisha provided was funded by the Gates Foundation, and a private investor would not have to come in and take care of that. That data is made available through someone else. So this slide summarizes some of the key benefits associated with MPT development. And these benefits could potentially go beyond MPTs. We're talking about investing in drugs that can prevent disease, and that need not be restricted to the indications that we're talking about for MPTs, STIs and pregnancy. This is leading to, this effort is currently leading to classes of new drugs, such as, a very simple example are humanized monoclonal antibodies, which we all know now from Ebola. That same technology is being examined to look at its potential for use in the prevention of STIs. In fact, the same group that has the Ebola antibodies has a grant from NIH to look at the development and use of those antibodies for the prevention of herpes. And they're looking at that in combination with antibodies to prevent HIV. Co-formulation technologies are needed beyond this MPT arena. Cancer typically involves more than one drug, so co-formulating them together is another way to achieve efficiency. And the technologies that come out that demonstrate co-formulation capability can be applied elsewhere. It's not like it's limited to MPTs. Other diseases, like the treatment of HIV, is moving towards the co-formulation of drugs. So that, again, you have a more efficient way to deliver these drugs. The preference for long-acting technologies in the populations that Trisha spoke out goes beyond MPTs and the populations that she described around the world. There are challenging populations in this country or in the rest of the developed world, pediatrics, for example, or the elderly, where it's difficult to get people to be adherent with their drug. And if you had a long-acting technology fall out of the MPT investment, those technologies can be applied elsewhere in a manner that is beneficial to product development in a large way. In terms of summary, I want to stress that MPT product development is ongoing, it's real. There is a sizable set of investments behind it from governments right now in a number of places. Those funding the funding that's in place now is from diverse sources, governments, both in this country as well as other places globally, and from private foundations. There are new technologies being developed, both at the drug level as well as the drug delivery level, and these technologies have ramifications and value outside of the MPT field. And it is a very partner-based field, as it has to be. As Bethany mentioned, it's very expensive and complicated. One group having all the assets and resources to develop an MPT is very unlikely. So the merging of assets, be they financial or expertise, is being organized in a meaningful way, largely by efforts from the IMPT. And this helps mitigate risks, both at the financial level and at the product development level. Thank you.
Well, thank you to all of our speakers, and I hope you are impressed with the power of MPTs and are impressed with the power for MPTs to have a very strong social impact.